Just to get started, there's a number of people that I would like to thank, because basically without the collaboration of others, what I've developed and worked on and I'm presenting to you here today would not have happened. So many colleagues, I firmly believe that research is much more fun when you do it together as a group. And so on here are not only some of the corporations that have funded our research in many different ways, but also my graduate students, my colleagues, who have been an integral part of the science and the research that goes behind all of the work that we all want to talk to you about today. What we're going to do today is talk about treatment of social phobia in children and adolescents, and I've broken it up into some different areas. I firmly believe that unless you really understand the psychopathology of a disorder, it's really, really difficult to design and implement effective treatment programs. So we'll spend some time today, a little bit of time today, talking about social phobia in children and adolescents, because again, we know there is a developmental trajectory, and we know that very young children can be socially anxious. We know that adolescents can be socially anxious. But it doesn't always look exactly the same at different ages. And so to understand what those differences are and how those differences might affect the way we do treatment, the focus of the treatment is really important. So we'll talk about a little bit about that this morning. Talk a little bit about what we know about etiology and some of the comorbid conditions. Talk a little bit about assessment strategies. And then also to talk about some of the efficacious treatment approaches that are out there. In the afternoon, we're going to focus specifically on social effectiveness therapy for children, which also includes adolescents. But we'll talk about the different components of it, and although we talk about lots of different treatments being CBT, you'll quickly find out that I'm more of a B than a CB. So we'll talk about social skills. I still sometimes deface my badge at ABCT and scratch out the C and put another A in front of it to go back to AABT. But we'll talk about social skills training, which I think is an important element for treating children with social phobia, and I'll tell you why I think that's important. We'll talk about the peer generalization sessions that we do as part of this treatment. We'll talk about exposure. We'll give you an opportunity. We'll ask for volunteers to help with some role plays. If not, graduate students are going to be commandeered to come up and help with some of the role plays. So, and then we'll talk a little bit about general management. If we have some time at the end, I don't know that we will, but if we have some time at the end, I'll talk to you about our very newest study, which is really using virtual reality therapy as part of the treatment. We've designed a school with some avatars, and we're actually starting to address some of the implementation and dissemination problems that exist, particularly with this treatment, by the use of virtual reality. So if we have time, we'll do that as well. Okay, so let's start by talking about the identification and social phobia and what it's like. And one of the things that we need to always think about, and you've probably heard this before, but from a developmental focus, we know that it's very common for children to have different fears at different developmental ages. So we expect things at different times because, again, based on children's cognitions and what's going on in their lives, different things can occur. So, of course, at infancy, we know that heights and loss of physical support, I mean, basically, if you're a little baby infant and you can't hold yourself up, if your mom suddenly pulls their arm away, you fall over. So that might be something that might scare you because falling over is not usually fun. When we get to about 1 or 2 years of age and toileting becomes the big thing, that's something that a lot of children can develop fears around. And as children go on and become more and more cognitively developed and have more independence, we see different fears start to develop in children. And for the most part, when we talk about them, if they come, they might stay for a while. And people often ask this question about social phobia and shyness. And they say, well, isn't everybody shy? We've seen there have been attacks on the DSM-IV on the diagnosis of social phobia, because people say, well, you're just pathologizing a normal condition, that there are people who are shy and they shouldn't be thought of as being diseased in that way. And certainly we're not talking about that. But what we are talking about is when shyness gets to the point that it's not developmentally appropriate, as it is in very young children who might be afraid of strangers. We're talking about social phobia in the extent that it interferes with functioning. So it either creates significant distress for children, or it prevents them from doing things that they need to be doing. So if those of you who have worked with children who are socially phobic, you know the stories. The one little guy who said to me, Dr. Beidel, the only time I've ever been able to be in a play is when we all got to wear masks, because that way nobody could see me blush. And that's the only play I've ever agreed to be in. Or another little guy who said, every time we have to do a play, I beg them to let me be on the stage crew, because I don't want to go out front. Okay? When we're talking about those kind of situations and that kind of behavior, then we're talking about something that is more than just being a little shy, or simple psychopathology of being a little shy and then you warm up in those situations. We're talking about something that we call social phobia. I often get ahead of my slides, as you'll see, because I get real excited about what I'm doing. But three things that we want to remember about when anxiety becomes an anxiety disorder. When it creates significant physical or psychological distress. So like other children, children with social phobia will often talk about physical symptoms. They'll talk about butterflies in their stomach. They'll talk about being sweaty. And for people with social phobia in general, there are really 4 symptoms, physical symptoms, that characterize social phobia and really in some ways distinguish them from people with other kinds of fears and phobias. One is blushing, one is racing heart, one is sweating, sort of sweating on the palms of the hands, and the other one is trembling. So if you talk to people with social phobia, what they'll say is, I can't eat in front of other people because my hand shakes and everybody will see my hand shaking. So I can't hold a fork because my hand is trembling. Or I can't hold a glass because my hand is trembling. Something that I know I tell people that my husband wishes I have is some people with social phobia can't write in front of other people. So I wouldn't be signing all those credit card slips in front of all the store clerks if I had social phobia, because my hand would be shaking. Well, we see that in kids. They're like, I can't do the math problem on the board. I know the answer to the math problem, but my hand will shake when I'm up on the board and everybody will see it and I'll be so embarrassed. So this fear of doing something that someone else is going to think is dumb or is stupid is what we're talking about when we're talking about social phobia. And kids will most of the time say that. I'm afraid I'm going to look stupid. I'm afraid the other kids are going to laugh at me. I'm afraid I'm going to do something dumb. That is what really characterizes the condition. And again, when kids can't go to school, 30% of children with anxiety-based school refusal have social phobia. So when they can't go to school because the anxiety is so high that they can't be in there, they can't get up and talk in front of the class, the adolescents will say, I'm not giving that speech. They can give me the F, I don't care. Okay? So it interferes with either going to school or with academic achievement in school. It interferes with social functioning. They say, I don't have friends like other people do. If they make a friend, they can keep a friend, but it's really hard for them to make friends. So the idea that they don't do things that other kids want to do. They get invited to birthday parties, but they can't go. One guy, his kid who said to me, he's 14 years old, he said, I'd love to go to the birthday party, but I can't stop throwing up long enough to get in the car and go because I'm so nervous about what might happen at the birthday party. And in the long term, occupational functioning. One thing we know about severe shyness in young children is when those children grow up. For girls, it's less likely that they'll go to college than girls without social phobia. For young men, it's less likely, it takes them longer to settle into a career, so they kind of bounce around for a while, and it takes them longer to get married, longer to develop a family. So all kinds of things can interfere. It's not that people with social phobia don't ever do these things, but they have a significant developmental delay in the time that they achieve what we think of as typical developmental milestones. And then when it's inconsistent with developmental age. So sure, your first couple days at school, lots of kids are scared. You get a new teacher and you heard she's mean. So yes, you're scared of your teacher and you don't want to go to school. But after months and months, if that fear hasn't gone away, then we're talking about something that might be a problem. When you move to a new school, sure, kids are afraid to go to the new school initially. But after a couple of months, we expect that that fear goes away. If that fear doesn't go away, then we're talking about something that is indeed something that may be considered in need of treatment. So we have all these different anxiety disorders, and I know you've had lots of talks on them, so I'm not going to go over all of them in detail. But one of the things, the social phobia, of course, is highlighted because that's the reason that we're here today, but also because social phobia is the most common anxiety disorder. So when we're talking about children, we're talking about at least 5% when we get to adolescents, maybe as many as 8% of adolescents who have significant levels of social phobia. When we get to adults, we're talking about 12 to 13% of the general population. So this is a fairly prevalent fear that people have. Okay. The diagnostic criteria we know very well. Fear of social and or performance situations. It's very hard among children to find kids who really are just afraid of giving a speech, right? Public speaking anxiety. And why is that? How many speeches do 8-year-olds have to give? Not very many, right? So they do have to get up and read in front of the class, which is, again, a developmentally appropriate behavior that might mimic public speaking in adults. Okay, the number one fear, if you survey the general population of adults, the number one fear is fear of public speaking. The number two fear is death, right? So as Jerry Seinfeld says, people would rather die than give a speech. So, but when we talk about kids, we're talking about that same behavior. So rather than getting up and giving a 6-hour workshop, what they're afraid of is getting up and having to read in front of the class. But mostly what we find in children is really fears that are more pervasive. The condition in young people is more pervasive than just having to get up and do something in terms of a public performance. What we're really talking about is, I don't know how to talk to other people. I don't know how to make friends. One kid, we do some diaries with young kids to ask them about the social situations, and they write things like, a popular kid spoke to me and I didn't know what to say, you know, creating anxiety in them. So in young children, what we see much more than just these very specific forms of public speaking is we see a broader pattern of fears encompassing many different situations and specifically encompassing social interactions with other children. We talked about endured with distress or avoided, and we talked about interference with social and occupational functioning. The last is it's not due to a substance or medical condition, which we don't see much substance abuse, thankfully, in younger children, so we don't really have to worry about that. And the medical conditions that are most commonly considered would be things like stuttering. So many children who have difficulty with speech, language, some of them, not all of them, but some of them often have social anxiety as well because they're afraid the other kids will laugh at them because of the way that they speak. There's a related condition that we'll talk about, but we always get questions about selective mutism. And so we'll talk a little bit about selective mutism. And right now the proposal in DSM-IV is that selective mutism will no longer be a separate diagnosis, but it will be folded in and become a developmentally appropriate form of social phobia found most commonly among young children. And at some point today, we'll spend a little bit of time discussing why that probably makes a lot of sense. So a study that we did a number of years ago now was looking on children with social phobia. And when I first started working in this area, a very famous child psychologist, but not Dr. Silverman, said to me, kids can't have social phobia because kids can't avoid things. I'm like, okay, maybe we should test that out. Because what they were saying is, you know, kids have to go to school and kids have to do what their parents tell them to do. And so I thought, well, let's give kids some daily diaries. Let's find out how it is that they spend their days. And the next thing that someone said to me is, kids won't fill out a daily diary for 2 weeks. They won't fill it out every day. And what I found out is if you've got really cool smelly stickers, kids will fill it out. So for a little bit of a, you know, for some smelly stickers, we did pretty well. So we gave them a nice diary and asked them to fill out every time something happened that made them nervous. And these are the results. So basically what we found, which was surprising to a lot of people, was that these distressful events were occurring every other day. So this was not just the 3 times a year you had to get up and be in the play at school. Kids were saying something happened every other day and it bothered me. And 60% of these events were occurring at school. Well, that makes a lot of sense because kids spend a lot of time at school. So these were where the events were occurring. And when we look at the frequency of those events, look what was on top. Again, it wasn't a public performance. It was peer interactions. So it was the fact that they in some way had to interact with another kid that was really the most common event that occurred for children with social phobia, followed by public performance situations, followed by testing. Okay? So there are many people who are afraid of tests and they're just afraid of tests. But there are other people for whom test anxiety really represents a more comprehensive fear of negative evaluation. So that's always a little bit difficult to disentangle. And then, of course, getting tests handed back is something that a lot of kids are afraid of. And I remember I went to parochial school a long time ago, and the priest would actually come in and hand back the test. So it wasn't bad enough that the nuns were giving you the test, but the priest came in to give you the results. And so that was really scary, even for those of us who don't have social phobia. But then other situations occurred. Like I said, you know, kids would say a little bit of bullying, or, you know, that a popular kid talked to them and they didn't know how to respond. So, but clearly it was these peer interactions and not knowing how to work. And that has influenced my thinking and that of the colleagues that I've worked with over the years as to how we go about approaching treatments. And so we've spent a lot of time looking at how to treat kids with social phobia, particularly within these problematic peer situations. So to talk about the detrimental outcomes, some of which I've mentioned before, but in children, what we see with severe social phobia is we do see school refusal. We see depression. So we often see kids who will say, you know, well, nobody likes me. I don't know how to make friends. You know, kids ignore me at school. So I should be sad. One young lady we worked with whose mother said to us, she's the kind of kid that 2 years later or even a year later, no one even remembers she was in their class. And she told us that the only way she knew the kids in her class was by their shoes. So she never made eye contact, spent her whole time with her head like this, but would associate voices with kids' shoes. And that's how she knew the other kids in her class. So if you think about you spend your whole year at school like this, maybe we'd be depressed too. Alcohol abuse and conduct problems, we often see, the alcohol abuse we see more likely in adolescents. And adolescents with social phobia will say, well, I've learned that if I can sneak a little bit of alcohol before I go to the party, I feel better. Okay, so they learn very early that alcohol can be used. We sometimes call it liquid courage. to help them get over a situation. And overall, alcohol is the drug of choice for people with social phobia. Unlike other anxiety disorders where there's more of a tendency to use anti-anxiety agents, alcohol is the drug that people with social phobia use in order to help attenuate their fear. And then, as I said, we have selective mutism. The issue with selective mutism is that when you try and do a psychiatric diagnosis on kids who have selective mutism, 98% of them in most cases meet diagnostic criteria for social phobia. And in one study, the other kid was really, really, really shy, but for some reason didn't meet diagnostic criteria. Now, of course, there are some other studies that have shown some lower rates, and we do sometimes see selective mutism in children who are on the spectrum. But those kids on the spectrum also have a whole lot of social anxiety as well, although not always for the exact same reason. But for the most part, the studies that have examined the psychopathology of these conditions have come to the belief that for most of, if not all of these children, that selective mutism is almost a redundant diagnosis. And people are beginning to think about selective mutism in the same way that we now think about school refusal, right? School refusal is no longer a diagnosis. It's a behavior that indicates that something else is going on. And so with selective mutism, when children talk to their parents, what they say is, I'm really afraid to speak outside the house. And we've been doing some new studies in our clinic where we've looked at, we have some wireless psychophysiological equipment, and we have a Wii, which my graduate students aren't allowed to play with unless we're playing with a kid. So, but we have a whole Wii system, and what we're doing in some of our studies is looking at differences in behavior and psychophysiological arousal when we have children with selective mutism in the group, when we have children who are socially phobic but do not have selective mutism, and when we have children who have no diagnosis. And it's very interesting. In some cases, what we find is that the children with selective mutism have a higher overall level of physiological arousal. So there may be something there. But yet, when they're in the room alone with their parents, they're chatting it up and talking, and somebody walks in the room and bam, they shut down just like that. So we're beginning to think about this as possibly a learned avoidance strategy. That may help some of these children sort of calm down in the situation. They decide not to talk. And when we talk about conduct problems, I've gotten in trouble in past with certain selective mutism groups who are composed of parents because they misinterpret my statement about whether or not children with selective mutism are oppositional. And so, and in general, what we do see with children with selective mutism is in a way they are kind of oppositional because people are going, talk, you know, and they don't talk. So, but I've never meant to say that they have oppositional defiant disorder because that's something very different. But what we do see in children with selective mutism, and by extrapolation with some children with social phobia, is that they do sometimes disobey what they're supposed to do, but it's because of their fear. Okay? Not because they just want to be oppositional. It's because their anxiety is so great that they avoid things, they refuse to do things because of their degree of distress. So when we're talking about conduct problems, we're talking about conduct problems that really seem to be secondary to their anxiety and not as a separate specific diagnosis. As I said, children with social phobia are less likely to attend college. Most of them will say, look, I hate taking tests, I hate talking in front of the class, why do I want to subject myself to 4 more years of that? So less likely to attend college. And then all of the things that we know occur in adulthood. So 50% of adults with social phobia have occupational impairment, social impairment in 44%, but yet only 39% of people with social phobia ever seek treatment. So a lot of people who don't even know that what they have is something that can be treated. And for a while, the Anxiety Disorders Association of America had a campaign out, you may have seen it, called Allergic to People. They're trying to get across the idea that just like people can have allergies to a lot of different things, there were people who had what seemed to be a physical reaction to other people. So they're trying to get the word out that treatment was available. An interesting study that goes way, way back to one of the first epidemiological studies ever conducted in this country had a very interesting fact in it. And that is that if children less than or below the age of 11 were diagnosed with social phobia or had that condition that early on, they were not likely to outgrow the condition without intervention. So having the disorder at a really early age predicted a very chronic nature for this condition. And so many of the studies in our clinic have focused on children between the ages of 8 and 12 because we see that as a really significant intervention point, that if we can get to those kids very early, those are the kids that just aren't going to outgrow it, and those are the kids that really seem to need our help the most. Talked about this a little bit in both American and Swedish samples. As men, shy boys marry later, become fathers later. American boys settled into an occupation later. Shy girls had lower academic achievement, most likely because they didn't speak up in class. They sat in the back and didn't talk, didn't get to know the instructors. And as women, shy Swedish girls were less likely to attend college. So some very significant long-term impairments. Okay. Are there questions on just the general diagnosis of social phobia? Okay. I'd like to spend the next part talking about the etiology, developmental factors, and comorbidity. Okay? So at different ages, we see different types of impairment and different physical symptoms. We see differences in the physical symptoms that children talk about and adolescents talk about. We see differences in the cognitive symptoms, and particularly in young children, we sometimes see the absence of negative cognitions in young children. And we see differences in behavior, and also these differences in types of impairments. When we talk about the developmental features of the diagnosis, we're talking about the fact that, first of all, children must have the capacity for social interactions. So this differentiates social phobia from conditions like what we might think of as classic autism, where children, probably because some neurodevelopmental changes or disorder that probably occurs at birth, if not before, are really incapable of being able to interact with other people in the manner that we conceive of as socially appropriate. The anxiety in children must occur with peers as well as with adults. And that's particularly important, as we know, because there's a power differential. So the fact that adults are taller, have deeper voices, have more ability to make things happen, we don't give children a diagnosis of social phobia if they're only having difficulty with adults. They have to complain about these same difficulties when they're interacting with their peers. Another important difference is that the way children express distress. So adults with social phobia try to hide their distress. They don't want people to know they're feeling nervous. And many of the symptoms, physical symptoms of adults with social phobia, you wouldn't notice and wouldn't see unless you were particularly adept or that person told you that they had social anxiety disorder. But with children, we often see many more overt expressions. So we see crying, we see temper tantrums. We know, for example, that there are differences in these kinds of reactivity. In studies in pain, for example, we know that as children develop, they're less likely to show outward expressions of pain. They have the physical capacity to control those better. And the same thing happens with anxiety. We also see freezing or withdrawal symptoms. So we see the running away, and we see the kids who will just suddenly stop. And again, we see that with the selectively mute kids. So they'll just shut down right there in front of you. And there's some literature that suggests that that really is probably due to some overwhelming anxiety creating a freeze response, perhaps even freezing or restriction of the vocal cords that may actually prevent speech from occurring. Children don't always recognize that their fear is excessive. So I've had a number of children who have said to me, everything would be okay if my mom would just homeschool me. Okay? I wouldn't have to worry. I wouldn't be upset with school. Nobody wouldn't be worried about people making fun of me. There wouldn't be any mean teachers. So not recognizing that school is important for lots of things besides learning math and English and all those things, that school provides the opportunities for lots of different kinds of development. So we see that children will often not recognize that there's something wrong with them. And also that, as I said, we rarely find this pure public speaking fear, particularly among young children. So it just is very, very uncommon. Lots of times kids will come in and they'll just say, well, I don't like to be in plays. But the more you talk to them, the more they talk about, well, I don't really have any friends, and no one wants to play with me at recess, and I'm standing in the corner and people don't even know I'm there. The advantage of the clinic where I work is that we do work on anxiety disorders in general. So we don't specialize in children, adolescents, or adults. We work with anyone at different developmental ages. And so when we've put some data together to look at using the ADIS and the ADIS for children and parents and look at the different social situations, you can see that there are some important developmental differences. So clearly, whether it's giving a speech, getting up and reading in front of the class, whatever it might be, it is the most common situation across all age groups. Children, adolescents, and adults, if we say, are you afraid to give a speech, or are you afraid to get up and read in front of the class? Yes, very much. Attending parties or social events, we see that that actually has an increase as people become older. And part of that is, in many cases, for children, birthday parties are kind of fun. But when you become an adult and you have to go to those office birthday parties or office Christmas parties or holiday parties, those are not necessarily so much fun. So people are talking about, you know, I have to balance the wine glass, I've got the plate, I'm supposed to be shaking hands. And so what we see is, because again, the structure and the expectations of what we have to do as adults is often different from what we have to do as children, we see that fears or the endorsement of that situation as creating distress increases as we age. Okay. Working in a group is the same thing. So particularly when we start to come to adolescence and there's more group projects, you have to work with someone in science class, we see an increase. And initiating or maintaining conversations, although there's a little bit of a decrease, that one was not statistically significant. And as I said, not many of the kids that we know are going on dates, particularly below the age of 13. These data were collected in DC. Washington, D.C., I don't know if things are a little bit different there, but there were a couple kids who were involved in group dating situations less than age 12 and had some concern about it. But using public bathrooms, this is one that people don't talk about a lot. They might talk about it in terms of shy bladder. It's always important to ask if people have difficulty using bathrooms, why that is. Is it because it's dirty? Well, then we're talking more about probably obsessive compulsive disorder. With people with social phobia, what we're talking about is, I don't want anyone else to hear me urinating. Okay? I don't want anyone else to hear me using the facilities, because that would be embarrassing. So we see that's not incredibly common among any group. But does exist at different levels, and particularly for adolescents seems to be a little bit more of a problem. And eating and writing in the presence of others, you see eating kind of goes up from children through adolescents and adults, and then writing actually goes down, again, because adults have more opportunity not to be forced to write in front of other people. This is just, again, to look at situations feared among children and adolescents, it's the same thing as before. It just gives you a bar graph with the exception of PE, phys ed classes, gym classes. Again, something that it creates distress in a number of children with social phobia. And even just being in the hallways at school. When we get to adolescence, we get to a lot of kids who are starting to be bullied, and a lot of the bullying goes on in the hallways at school. We talk about avoiding, and this goes back to the slide I talked about earlier where people said, well, you can't diagnose children with social anxiety disorder because they don't avoid. Clearly, children with anxiety disorders, with social phobia, have avoidance in lots of different ways. And they will not, one of the most common ones that does affect their academic functioning is they will not ask questions in class. So they will not ask the teacher a question either from the class room setting or coming up to the teacher. So they often miss the homework, don't understand the questions to the test, and they are just not going to ask anybody. So they get lower grades on homework, lower grades on tests because they are not asking the questions that they need to know. And eating, again, eating in front of a group can become a problem. We've had a number of kids with type 1 diabetes who would not eat at school. And were really getting in danger of their medical condition because they refused to eat in a group. And the schools wouldn't let them eat by themselves because they didn't understand why they wouldn't eat with a group. So we have different situations that occur and that children avoid and can create very important problems. Another difference is when we start to look at comorbidity. And we start to look at what are the differences in comorbidity. And a caveat that I need to put out here is that these samples were children who were recruited specifically for our treatment programs. So we were looking here for children with primary social phobia. So this is not a general epidemiological sample. We started out with kids who had primary social phobia and looked at the presence of any comorbid conditions. So what we found was that there were more comorbidities among children than among adolescents. And I think that's partly because, again, children's verbal skills are less than adolescents, and sometimes it's difficult for them to actually describe what's going on, and so we're making some guesses about what this might mean or what that might mean. So we do find that the most common one, as you might suspect, is generalized anxiety disorder. So about a quarter of the children with primary social phobia also meet diagnostic criteria for generalized anxiety disorder. A few with ADHD, a number with different specific phobias. And as you see, again, developmentally, selective mutism is more common among children than it is among adolescents. It's rare to find adolescents with selective mutism, but as we were talking to a smaller group last night, I was just saying that my student Brian, who's here with me today, actually just successfully treated a 17-year-old with selective mutism who had never spoken outside of her house in entire 17 years, and now she's doing very, very well speaking to everyone. But it's rare to see selective mutism at that late of an age. Again, separation anxiety disorder, which you don't see as much in adolescence, and then obsessive compulsive disorder and depression, rare, but they do exist. And again, in this sample, we would have ruled out children with very severe depression because we were doing a behavioral treatment for social phobia, and we couldn't ignore if they had severe depression and needed some other form of treatment. So a little bit more on selective mutism because it's an area where we've been doing a lot of work recently. And as we know, it's a reluctance to speak. We used to say a refusal to speak, but then people thought that was too oppositional. So a reluctance or refusal to speak in some situations despite speaking in other settings, usually at home. And the children have the capacity for speech in that situation. So if we look at the relationship of this and we look at the data that exists, again, to sort of make this point that we're probably not talking about a comorbid diagnosis, but perhaps a form of social phobia that may represent a more severe form of this condition. If we look at family history, we can see that among people who have social or selective mutism, their family histories are described in the literature as being characterized by avoidance, anxiety, and a preference for being alone. So in many cases, when you talk to children who, or not talk to children, but talk to the parents of children who have selective mutism, they will say, I'm kind of like that too. I didn't speak in first grade. I've always preferred to be by myself as opposed to being around other people. So we see this, this pattern within the family of social reticence that exists among these children. There are some data to suggest that communication disorders also exist in children with selective mutism. But if you really, really look at the literature, it's very interesting. What you find is that, yes, a disorder exists, but it's not always the same disorder, and it's not always a disorder, a communication disorder, that is more prevalent among children with social phobia than without social phobia or any diagnosis. So although some of these children do have some communication disorders, they don't always have one specific disorder that would point to that as an etiological factor. They do have some disorders, but it's different. In some cases, it's an articulation disorder. In some cases, it's a processing disorder. In some cases, it's a hearing disorder. So it's a number of different things that seem to be related, but it doesn't hold up in the sense of any one disorder being more common. And if anyone had the money, there have been studies among adults, for example, to look at vestibular dysfunction is a good example, because at one point we thought that adults with panic disorder, they might develop that disorder because of a basic vestibular dysfunction, inner ear problems, middle ear problems that could make you very dizzy. And a small study that looked at the general population found that there's just as many people in the general population who has vestibular dysfunction, half of whom didn't even know they had a vestibular dysfunction. So just because there's a physical disorder associated with it doesn't make it an etiological factor. Okay? Again, a few studies that have looked at neurodevelopmental disorders and have suggested that this might be a reason why children are selectively mute. And again, you find the same thing. A few with some motor problems, gross motor problems in some cases. Then another study is no fine motor problems, not gross motor problems. So all of these things that among young children seem to be prevalent, but not pointing to a particular event or a particular cause. When we look at the studies that have looked at comorbidity, so have started with samples of kids with selective mutism and have looked at what other psychiatric diagnoses do we have, we see the prevalence rates. This study is a little bit unusual with only a 44% rate, but it had something to do with their sampling procedures. But we see that as many as 60% and up to 97 to 100% of children with selective mutism also have social phobia, so despite the selective mutism. So again, drawing together some lines. One of the issues with children with selective mutism, or this whole literature, is really this paradox between what children or parents particularly say is wrong with their children and what clinicians often observe. So if you've worked with children with selective mutism, you know that they'll be sitting out in your lobby or waiting room, chatting, and as one little boy used to do with me, the minute he saw me come around the corner, he'd go, okay. Typically, this is not what we see. This is not the stance we see in someone who is anxious, you know, sort of like this, like, I dare you to make me talk. So this idea that maybe something else is going on. Maybe sometimes parents are really what we call overinterpreting the silence. When we started our series of studies, we weren't sure, is there something else going on with these kids? Maybe they're anxious, but are they really, 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 really anxious? Or have the children learn to use this vocal avoidance as a way to modulate their distress and a way to decrease it in social encounters? Because, right, if we're afraid of something, what do we usually do before we come to the clinic here at FIU and learn that's the wrong thing to do, right? So we're afraid of something, we run away, right? So we don't like spiders, we get somebody else to kill the spider, okay? If we don't like, flying in an airplane and we have enough money, like, some former football coaches that we know, we get a great big bus and we drive to the next game that we're going to comment on, because we avoid the things because it makes us feel better. So should we be conceptualizing selective mutism in the same manner that we now conceptualize school refusal? Should we be thinking about it as a behavior and not as a distinct disorder? This is what I was talking about a little bit earlier. We approach this question. One of my graduate students, Samantha Scott, is just finishing her dissertation looking at this idea of a freeze or a fright response. So when you get into a situation, like when something scares you, the first thing we do, we don't think about it, but the first thing that happens is we sort of attend to it and freeze, right? Like, oh my gosh, what was that? Okay, and then we start to process it, and we have the sympathetic activation of our nervous system, right? So we have that sort of fright or flight response that begins to happen. Our heart starts to race really fast. So a car pulls in front of us, and you notice there's like a little second delay before your heart starts going, and you start feeling a little bit dizzy. So we have this uproar of the sympathetic activation of the nervous system, which includes dizziness, lightheadedness, palpitations, your mouth getting dry, feeling some numb, muscle tension, and this feeling of unreality. And as we go up, we have this fight or flight response. But then what can happen is if the event is still there, we don't know how to deal with it, we end up with actually a fright rather than a fight or flight, a fright response, which is characterized by tonic immobility. So you're really unresponsive. You still have these physiological symptoms. I know this may be hard to read. Tachycardia, vasodilation, we get high emotional arousal, we get a fear, but you'll see this in animals, right, where they freeze. Okay. So it's kind of, if the anxiety gets that high, you can get to this same level of freezing. And what happens here is one of the ways in which we get tonic immobility is there are data to suggest that you get a tightening of your vocal cords, okay? And if you've ever been really, really angry, your voice gets really tight and you kind of start to squeak and it's harder to get the words out. And so it may be that we do get this tonic immobility. So I'm arguing both sides of the coin here because that's hopefully what a good scientist does is maybe this is an avoidance strategy, but let's look at the other side and see what physiological arousal actually does, because that's, to date, what people have not done with kids with selective mutism. We assume because they're nice, we're nice people, we're nice clinicians, we're nice to them, they're not talking to us, well, wow, they must be really scared because I'm a nice person. I don't make people afraid, so they must be really, really afraid if they can't talk. We don't know that, okay? Maybe subjectively, but how about physiologically? How about something that they can't control or we can't interpret? So, and if you don't, if something doesn't happen, if your body doesn't modulate this, then what happens is you start to shut down. Parasympathetic activation may become overwhelming, and in the bottom, you could faint. And this is what we know happens with people with blood or injury phobias, right? So if you think about, a lot of you nodding your head, great. You have this diphasic response with blood injury phobias where you have this boom, this sudden increase in your blood pressure and your pulse rate, and then all of a sudden, boom, it drops down below your resting levels, and that's why people faint. because your blood pressure is way down, your pulse rate's down to about 40, your systolic blood pressure is down to about 60, you keel over. That's this. Okay? So what might be happening is that something might be wrong in the emotion regulation of some of these kids that keeps them over here in this typical sympathetic uproar, but maybe for other kids there's a problem with their emotion regulation and they go up into this tonic immobility. So these are my graduate students setting up the equipment, and you can see that's Brian is here with me today. That's him in the background. But these are my students, and if any of you know, this is Melissa Nieves, who's was an undergraduate here and now is up in my lab. And what we're doing here is we decided we were going to try and really address this by actually collecting data on physiology and behavioral observation rather than just asking kids if they're really nervous. And so what we did was we thought, well, a lot of times I use these old role-playing tasks where people would sit and somebody would read something from a card and the other kid would answer, and it's actually kind of odd because kids don't do that. And so we decided, well, what do kids like to do? And I asked my graduate students if we could buy one thing that would work for young kids through late adolescence, what would it be? And it took them about 5 seconds to say Wii. So we bought a Wii, and we also have the Noldus recording system and also a Mindware wireless psychophysiological recording system. So we can record heart rate, skin conductance response, and respiratory sinus arrhythmia as people are engaging in different situations, and they can actually move about our clinic or about this room, and they can play games without being attached to the wall where all the wires are. So it's radio transmitted over into another room where the data are being collected. So we have this system, and when you're a grown-up, it can fit in a fanny pack, but sometimes with little kids, the fanny pack's like actually pulling down their clothes because it's not really heavy, but it's heavy when you're 6 years old. So in some cases, we use little backpacks on the kids. So we have this awkward role play. We wanted to get a more natural strategy. So we have physiological assessment with 10-minute tasks, and we can do minute-by-minute analysis of what happens in these different situations. So we have 2 tasks. The task is that the child, and we have 3 groups. We have children with selective mutism, children with social phobia who do not have selective mutism, and children with no disorder, no psychological disorder. And what we're going to look at here is skin conductance when an adult they don't know comes into the room and says, do you want to play a game? Okay? So they come in and they play a game, and here's the skin conductance of the children. It's an aggregate group. We're doing single case design, so we've got 5 kids at this point. And what you see here is baseline. Stranger 1 comes into the room, plays for 10 minutes. Baseline, a different stranger comes into the room, so we can see if we can replicate this at both times. That's the line of children who have selective mutism. Higher marks on this graph indicate more physiological arousal. Now, if you don't know much about skin conductance is a measure of general arousal. So different things. Anxiety can make your skin conductance go up. Thinking very sexy thoughts can make your skin conductance go up. Being angry can make your skin conductance go up. So here, when we're talking about arousal, we're thinking about it in terms of anxiety, but you'll see we have heart rate data to back it up. But just in general, it's a more gross but quick measure of physiological arousal. So what happens when the kids come in and the adult comes in? The kids with selective mutism will pick up the Wii, they'll be compliant, and they'll start to play. The adult then asks them a series of questions to try and engage them in the situation. Kids with selective mutism stand here and just keep playing the game. They don't talk at all when they're in that situation. So here's the kids with social phobia. Okay? So much lower line, still have a little bit of a peak when the stranger comes in, okay, but not nearly the level of physiological arousal. They do talk, okay? But what you can see is that with these big spikes and then these differences that even if they're these and you can see we do have baseline differences. So if you start to look at the changes in these slopes, you see that kids with selective mutism have a much bigger peak overall, but it also looks in some ways like maybe the no talking is helping them modulate a little bit more back down to where they were. They're not staying high with that. And then we have the kids who have no disorder, who again, when a stranger comes into the room, does have a peak. But then they're yakking and telling the stranger they're not doing the game right and, you know, so getting into it. So you can see some very different lines for skin conductance level in these situations. Same thing happens when they're interacting with peers, only it was really even more interesting because what happened was 3 out of the 5 kids, instead of standing next to the other peers, there were 2 peers that they played with because we wanted to see if the other 2 peers came in and started playing, would the kids get up and join them because we had 3 controllers. So 3 out of the 5 kids with selective mutism got up and played, but physically stood either behind the other kids or in front of the other kids, not in line with them, as if deliberately trying to not make eye contact, not have to interrupt. And it was a very conscious effort on their part. If you watch the videos, the other kids come up and initially they'll all be standing in line, and the kids with selective mutism will deliberately back up and move to a different part of the room or go forward to a different part of the room. They would play the game, but they were physically distancing themselves as if they were trying to avoid. Okay? Whereas kids who had social phobia stood in line with the peers, they played, they weren't like, you know, making the big swings on Mario Kart, they were very restricted in their movements, but they were playing with the other kids, and again, had a lower overall level of arousal when they were engaged in the game. And then again, our typically developing kids down at the bottom line. So some very different patterns of physiology that might suggest some active avoidance behaviors on the part of kids with selective mutism, but in response to their overall level of physiological arousal. Okay, so we have heart rate data that looks exactly the same, and we have respiratory sinus arrhythmia that looks very similar, but I didn't want to bore you with like all kinds of graphs today, but in general, what it seems to suggest is that maybe we can think about this behavior as, yes, overall physiological arousal that was there even at baseline when they were talking to their parents, but then perhaps a deliberate attempt on their part to use something to minimize or decrease their level of arousal, whereas the other kids were not getting necessarily so aroused to begin with and didn't necessarily have to engage in these behaviors. So if we think about school phobia and think about it, we know it could be due to many of these different things, but the one thing we might think about is to, again, think about selective mutism as a developmentally appropriate behavior that goes along with the diagnosis of social phobia. Again, not the only reason kids might be selectively mute, but a reason for that behavior.